solo, viaggiando nel buio. Ora la strada si fa scura nella notte. Io sto tranquillo, aspetto il turno nella notte. È qualcosa che mi possa prosperare. Ho la fiamma per poter continuare. Ci penso adesso che sono da solo, viaggiando nel buio.
Nella vita non c'è un verso da seguire, perché pure se ti vedi non riesci a capire i come, quando, forse, se. Le cento più domande che vorrei fare te, che non pago, accendi un'altra sigaretta mentre io placidamente attendo senza fretta e spesso la mano non tesa al tuo universo. Mi sono chiuso a me stesso, confesso, ed è così che ti ho permesso di giocare, velare, lasciandomi aspettare l'occasione e l'illusione che domani sia migliore di questo. Ma ormai ho scoperto il contesto, il futuro non lo creo con un gesto, né con rimorso di quello che ho perso, ma con la speranza, yeah, di un mondo diverso.
Guardiamo perché non si sa nemmeno cosa, ma chi di noi ha veramente la sua meta? Pensarci adesso che siamo soli, viaggiando nel buio. che esce di casa sbattendo la porta, fa le scale due alla volta ed è strada, la vera casa. Cerca quell'uomo che sta sempre in giro, quando ti serve non lo trovi mai, ma troverà qualcuno che lo tiri fuori dai guai. I soldi sono pochi come sempre, ma troveremo un modo per pulire la mente. Mario sta chiuso in casa, seduto sul divano, comanda il mondo intero con quella scatola nella sua mano. Mangiare, dormire senza pensare, di vivere non se ne parla più, l'importante è guardare, 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 arrivare dove arriva la TV. No, non c'è differenza, chi muore per strada, chi a casa senza violenza.
Hey, my friends, are you ready for the next episode? See you soon. Allora, ragazzi, don't you think that I'm a little bit tan today?
Yeah.
Yeah.
Wow. What did you do?
But I was in the shadow. I swear, I was in the shadow.
You were in the booth. With sunscreen or not?
No sunscreen, but it's literally always in the shadow. Yeah.
But I wonder, I see here once again Tilak from Melbourne saying hello. It's 3 a.m. there. And I just wonder, Tilak, now that you watch at 3 a.m., do you watch, I mean, do you have the volume on and all this, you know, or you try to do it in a silent way?
You mean he's just looking at the pictures, just at the figures?
Yeah, headphone, yeah, correct. course.
Yeah. So, ragazzi, how are you, my friends? This is the episode number 18.
Episode number 18. Yeah. And by the way, I think that tonight we have to be on time because immediately when we finish, there is the final of the EuroLeague, you know,
Ah, yeah.
basketball that many people would.
Basketball.
Basketball, yeah.
Basketball.
Come on, who cares about basketball?
Well, many people.
Many,
And
many.
we have also a Greek participation in the final.
Ah, yeah.
Panathinaikos, Real Madrid.
Mm.
Yeah.
Great.
But let me show you before we start what happened last Sunday when we finished the episode. Do you remember that I told you that there was a football game, like also in Turkey, there was the football game
Yeah.
Yeah.
would be the determinant one. That was the same in Greece. And the team from Thessaloniki was, if we won, we would get the championship.
Mhm.
And I will just show you for a moment what happened when the episode finished.
Wow.
What's going on here?
Wow.
Yeah, this is like
That's
100,000 people,
My God.
12 o'clock in the night in the football stadium because PAOK won the championship and is now the champion in Greece.
Wow. My
Today, I
goodness.
hope we will be the champion of Turkish League. This is
Next
the
year,
last
my
week,
dear.
and I'm so excited. And
Wow.
I'm always checking the news, what's going on, because the match is going on right now.
Great. Wow. But this is amazing.
And
Amazing.
did you go as well?
You cannot imagine. I mean, it was, you can imagine, of course, because Napoli won the championship last year, so you can understand more or less the situation.
Yeah.
But it was really crazy.
Did you go? Did you go?
No.
You didn't. But not even at the party afterwards.
No, it was too late. But I stayed awake until late, watching at least what was going on, and also listening, because if you just open the window, you could listen.
Wonderful.
In the city, it was a big
Okay,
party.
so we have to go fast. Yeah.
Yes, we have to go fast.
Yeah. So
Question of the week.
Sebi, question of the week. Sebi. This is a very difficult question. Did you ever miss a melanoma? Yes, no. Sometimes it's not this question. Yes, no. Did you ever miss a melanoma?
No, never. No,
Never.
never lost melanoma.
No.
Hopefully never. Hopefully never.
Hopefully never. Let me tell you, I missed many. Not only because I missed, of course, those who never came back, but also some very often melanomas in patients who came back, and then I realized, oh my God, I missed it.
Of course.
Okay, so yes, 73%. Yeah, no, 27. By the way, yeah, lucky people. Yeah.
Wow.
Well, and it's my task to start. Sebi. Sebi. Wonderful. Allora, errors. I will speak about the paper dedicated to errors, but I decided not to speak about only one paper, but just a few, just very briefly, starting from this one: medical malpractice issues in dermatology, clinical safety, and the dermatologist. So, of course, dermatology is not among the specialties that are much more frequently, let's say, involved in malpractice legal issues. But as you can read from the abstract of this paper, a great variety of clinical scenarios in dermatology can potentially give rise to a claim, and melanoma is most susceptible to the risk. Okay, so it's definitely melanoma. It's definitely one of the main problems in dermatology concerning malpractice claims. As you can see here in another paper published a few years ago in 2017, not by dermatologists, by the way, but by otorino, come si dice, NTN, ENT people. So they were reviewing the literature about melanoma malpractice litigations, and they found 80 cases in the literature. Of those, not in the literature, but in the legal database of the region they explored, and they found 80 cases. Of those, 50% were resolved in the defendant's favor, so meaning in the doctor favor, yeah, and 50%, of course, in favor of the patient. Okay. In greater than 80% of cases, there was a leaked misdiagnosis. So the problem was misdiagnosis. Okay, not management issues, no therapeutic issues, but misdiagnosis. Okay, 80% of them. Okay, and the most common location for melanoma were melanoma with legal problems were the extremities and the head neck region. Facial melanoma, lentigo maligna. This is extremely important to remember. Okay, and there is another third paper published in 2018 in American Journal of Clinical Pathology, Malpractice Concerns Defensive Medicine and the histopathology diagnosis of melanocytic skin lesions. So what is the result of the fact that melanoma is top one problem in dermatology and of course in dermatopathology? And what is the consequence of the fact that, of course, 80% of problems are related to misdiagnosis? This is the consequence. The consequence is that of the pathologists interviewed for this in this paper, by this survey, 27.5% reported that malpractice concerns influenced them toward a more severe melanocytic lesion diagnosis. Okay, so 1 out of 4 pathologists are more prone to diagnose melanoma because of defensive medicine issues. And
it's even worse. 1 out of 4 declare that they are. There's obviously an additional percentage that does not like to declare this.
Yeah, you are right. You're right. And this is the end of our professional life. You know, when we are starting to take decisions based on defensive medicine, this is the end of our professional life, because we will start not to take decisions in the interest of the patient, but we will start taking decisions in the interest of our self, of our buttock. Okay, and this is a severe problem. And
of course, this is not only for JP. Sorry for interrupting you. This is not only for pathologists, but to some extent, it can be also discussed about clinicians. I mean,
of course,
you are much more prone to do excisions in order to avoid.
Exactly. It's a state of mind. If you are not thinking about the patient anymore, but you think about yourself, then everything is lost. Yeah. And then finally, I would like to mention this paper that we published a few years ago, in 2021. Now on the side of the clinician. Yeah. Clinical clues to avoid missing melanoma when morphology is not enough. Okay, when morphology is not enough. Fortunately, just in a very small percentage of cases. Let's say 10%, 15%, 20%, but not more than this, okay? So how to avoid missing a melanoma when morphology is not enough. By the way, before that, please remember that we can miss, as clinicians, we can miss a melanoma not only because we are not able to recognize it, but also when we are not able to see it, you know? Melanoma can be missed not only when the lesion is lacking specific morphologic clues, but also when the lesion is localized on covered areas and the patient is not undressed by the clinician. This is also very important, you know? Of course, when morphologic criteria to diagnose melanoma are lacking, there are 5 particular relevant clinical clues to be considered in order to avoid the risk of leaving a melanoma untreated. And what are these 5 clues? First of all, by far, and I know that all these beautiful friends agree with me, patient age is the most relevant clinical factor influencing the diagnosis when morphology is not enough. Because in a child, we should not think about melanoma as the primary possibility, while in an elderly person, of course, melanoma should always be in our mind, okay? Sex and location. Sex is not so relevant, but location is extremely relevant. Remember that many litigations about melanoma involved cases located on the head neck region and the extremity. And lentigo maligna, we know very well, it's very often very difficult to be diagnosed. So we have to apply very rigid rules in order not to miss melanoma. And we know how to do it today by applying, for example, for the face, the inverse approach. The third rule, in my view, which is also very relevant, is the comparative approach. This lesion, which is equivocal in some way, so it's in the middle, in the morphologic gray zone. It should be treated differently if it's belonging to the patient in B with multiple atypical lesions. So we are more tolerant with a lesion like this, while in a patient having just a solitary ambiguous lesion, we should try to excise it. You know, it's not the case to lose time with an let's say an atypical gray lesion. Number 5, and we finish, palpable and or pink lesions. This is something very relevant because in the differential diagnosis, there is an aggressive type of melanoma, which is nodular melanoma, which is amelanotic melanoma. So in these particular instances, the rule is very simple. If we don't know what it is, if we cannot give a precise name of a benign lesion to a pink or nodular lesion, it's better to excise it. You know, for example, in this case, this was it was a melanoma, but it was clinically looking like a cherry angioma. Okay, or look at this lesion. Clinically, it's for sure a seborrheic keratosis, for sure. Okay, dermoscopically, I mean, we don't have too many of the nice features we usually see in seborrheic keratosis, like comedal-like openings, miliar-like cysts. So the clinician was unsure. So fortunately, he decided to remove this lesion. But this is a melanoma, and a thick one. And that's why, I mean, I'm laughing because I'm speaking about this rule very often in the last period. Let's give back to seborrheic keratosis full respect and dignity. Seborrheic keratosis should be respected, should be a diagnosis based on specific criteria that we are clearly seeing in a lesion. Like in this other case, this is a seborrheic keratosis. Clinically, it's not so sure dermoscopically, so we must excise it. You know, we should not underestimate the possibility that this could be a melanoma, and this is a 3.7 millimeter thick melanoma. I show you another horrible case, which is again very similar to a seborrheic keratosis, not only clinically but also dermoscopically. But since there were, let's say, the clinician was not convinced about the diagnosis here, he decided, fortunately, to excise the lesion. And can you imagine, this is an 8.5 millimeter thick melanoma. So it's a beast, okay? So we should really consider the differential diagnosis between seborrheic keratosis and melanoma as a very, very serious stuff, and we should not underestimate it. Okay, I conclude saying among the 5 clinical criteria which are important for the diagnosis of melanoma when morphology is not enough, history is not cited. It's not cited by purpose because, in my view, history is not really an important criterion because it's subjective, it's not objective, and sometimes it's bringing us out of the right line. So it's better, believe me, not to base our diagnosis when we are unsure on the history. And with this, I give you back
Wonderful, wonderful.
the word.
You know what? Since I know the fight that you are giving against history, and I support you, I'm with you, of course, maybe we should just rephrase saying that we refer to spoken history.
Yes.
We refer to the history which arrives to you as a spoken information by the patient or by the relatives of the patient. We don't speak about the objective history. We don't speak about the scenario that you have a photograph of the lesion 1 year ago or 6 months ago or whatsoever, and the photograph today. This is reliable history because there is evidence about what happened. We speak about, we refer to wording. I mean, the stories that the patient.
Exactly.
There is a very, very nice quote that I love from Taha, saying that expert or beginner, whatever, obey the rules forever. This is very, very nice.
Very true.
Yeah, also the content is important. I mean, these rules, as suggested by the quote, are not just for the people that begin today. They are for everybody, and these rules were made by mistakes that we have done ourselves, not when we were at the beginning, today, yesterday, or the other yesterday. So that's how these rules were built, because they are based on things that happened to me, to you, to somebody else, and that's why we created these rules. So they should be applied by everybody, including ourselves, of course.
I like it very much. Very, very good. Very good.
Suspect the worst, expect the best. That's also nice. That's by Nisa. It's by you.
Nisa.
That's also nice.
The worst, expect the best. Yeah.
Yeah, we have.
There is a question: was any metastasis in case with melanoma 4.7 and 8.5? Yes, in both. Unfortunately, both cases relapsed. Yeah.
So, Jeppy, the only problem is that with these papers about the legal issues and so on, you induced a little bit of terror.
Yeah,
it's stress on me, for sure.
No, it's depressive. Whenever we speak about medical legal issues, I start, being in a bad shape. Yeah.
And imagine when AI comes into play, like really actively, then the medical legal issues are going to be tremendous. Like AI says the opposite of what you think or what you do, and why didn't you do what the AI said, or why did you do what the AI said, and then it turned out not to be anything.
Yeah. Okay, Emilio, what did you prepare for us?
Well, a collection of mistakes that I did.
Yeah. Okay.
Guys, before we proceed with Emilio's, can I ask for a favor?
Yes.
Sir, a very dear friend of mine, colleague, dermatologist, who is I'm right now in my medical practice. She's here now because she noticed today a lesion that came out like 2 weeks ago, and she's waiting like in the waiting hall for us to finish so that I can take it out. And because I don't want this to be in one of my mistakes. May I share my screen for a second?
Yes, show us.
Of course.
Show us.
Allora.
Oh, but this is now a live consultation from.
Yes, it's a live consultation.
So she will be examined by 250 dermatologists.
Yes.
It's exactly that. It's exactly that, and that's why I want to do it with all together, because it's a very dear friend.
Okay, so this is the lesion.
Come on, we don't see anything.
Yeah.
Well,
It's
it's a tiny papule, not big.
And- exactly.
Yeah.
And
Yeah, but in the
this is dermoscopy. Let me go closer.
Dotted vessels.
tiny spits,
are they
something
vessels?
like that.
Vessels,
It's
yes.
a tiny spit.
Vessels, yes, probably.
Yes, that's
Yeah,
two
that's
weeks.
probably spits.
Yeah.
You agree with
Is she
spits?
young? Is she young?
40 years old.
40. Okay.
40.
Yeah, it's a
Schizoid. Let's say schizoid.
newborn Spitz, newborn. For
Yes,
newborn
because,
babies, we can, yeah.
because of the very recent appearance, I was thinking maybe a DF, like a DF from the beginning.
Yeah,
And-
could be. Is it
Right,
thermal
right.
palpation?
Yeah.
Not that much. Not that much.
Not that much. Okay, then
What
excise.
do you mean? What do you mean with the ADF?
Dermatofibrosis.
DF. Okay.
Yeah.
Yeah. Well, but
So
Let us
spits.
start with the pathology.
this is not a location for dermatofibroma. This is not a location for dermatofibroma.
Yeah.
So
Well, but I mean, you are going. No, don't tell me that
So
you are that on a Sunday evening you are excising a lesion in a patient foot.
she's not a patient. She's a friend and a dermatologist.
She's the
She's
okay,
a friend dermatologist
Understand.
who saw it today.
Understand.
Yes, I'm excising it.
Okay, but this lesion has this patient has a very high risk factor, and the high risk factor is that she's a dermatologist. Yeah.
Yeah, exactly. So it's going out either way. I just want to get a feeling.
In terms of management decision, the answer is clear cut. It's the rule number 5. It's a nodular lesion. You have no clear cut, confident, definite diagnosis, so it goes out. Huh? Nobody will disagree.
Yeah. Exactly.
Thank you so much.
Konstantinos, let us know with the pathology result.
I will. For sure I will. She's actually now watching the Dermoscopy Happy Hour. She's like inside. I can see her.
But I can tell you, I put my money on a benign lesion.
Me too.
Yeah.
Yes, but don't change the management that we agreed.
Yeah.
No.
Excellent. Totally agree. Thank you so much. Emilios, please proceed. Sorry to interrupt. But this needs to get out of the way because it's waiting inside.
Of course, you remember the story with the lesion located on my leg. Now I don't.
Yeah.
But one day, maybe I will repeat it again, also live. Wonderful. Okay, there was another comment by the way, before I share that you guys are lucky that we don't practice in the USA. That's a malpractice nightmare. Yeah. It's true.
Yeah.
Wonderful. Okay, so guys, let's go. We start with, this is the first case that we're gonna see. For the first and second, we will have, I have also a poll that the audience can help me a little bit with this presentation. This is the clinical aspect of the lesion located, you see where, that's dermoscopy. Okay, and now Sebastiano, if you could launch the poll, and the poll asks a management question: what would you like to do with this lesion? Ignore, follow-up, biopsy, or excise? And then when people vote, you will also tell me, my friends, your preferred choice: 1, 2, 3, or 4. Let's see. We have 40-40 for biopsy and excise.
Okay, so we can vote and we will see the winner. I vote for biopsy.
You vote for
Biopsy, excision, for sure.
Excision? Okay.
Excision.
or
No
biopsy?
way. No
So-
way. Biopsy.
Jeppy votes for biopsy and Niz and Konstantinos for excision.
Yes.
Okay,
Yeah.
good. By the way, we had 17% that chose follow-up and 2% that chose ignore. Now, the point that...
100% melanoma. 100% melanoma.
100% melanoma, yeah. So what we did in this case was to excise the entire lesion because we thought, as Nisa suggests, that it's quite sure that this is a melanoma. Therefore, let's excise melanoma in situ, obviously. So let's excise it, and then it's the end of the story, because in lentigo maligna, anyhow, as we discussed in other times, we don't need to do much. Just excise the lesion and that's all. The point is that we excised it, and the result was, without
Don't
any
say SEPK. Don't
without
say.
any doubt, solar lentigo. Yeah.
No, it's not acceptable.
Without
Change the pathologist.
No. It's a pathologist that you know very well, and it's of course a lesion that we ask the pathologist to be very, very exhaustive in his evaluation and so on. So this is an example of a solar lentigo that does not conform to the rules. This might happen. It's okay. The mistake here probably, or I mean, the thing that we could have done better is, since the lesion was located on the face, is before excising the entire thing to do a small partial biopsy. Because what we did eventually was to do an entire excision of a solar lentigo, which could have been avoided if we first did a partial biopsy, either a punch or a shave, and this would solve the issue that this is not a melanocytic lesion. This is something that might happen, and of course on the face, it's, in my opinion, particularly relevant to apply this strategy. Case number 2, that's the clinical. This is dermoscopy, and let's try once again, Sebastiano, the poll. Ignore follow-up, biopsy, or excise. That's located on the trunk, so it's a little bit different story.
Yeah, but in this case, there would be definitely
Okay.
clear-cut winner. Clear-cut winner.
Let's see. Let's see the answers.
Even though,
Excise
yeah,
90%.
even though not we cannot be sure 100% that this is a melanoma.
What's the alternative?
A very unusual nevus.
A kissing nevi.
Yeah. So excised. Diagnosis, seborrheic keratosis.
Ah.
Oh, come on. Emilios.
No, but I agree with you. I am with you. We excised it. We did the same as you think. We did the same. I mean.
No, Nisa is saying that we cannot accept that this is a seborrheic keratosis. It's something which is not, let's say, acceptable, you know.
Yeah. Okay. But for the moment, I would say that these mistakes do not have a huge consequence. So let's see one more similar. That's the clinical. This is dermoscopy. Should we launch the poll again?
Yeah.
Yeah, let's do it quickly.
Don't say again solar lentigo or seborrheic keratosis. I will not take it.
Ignore follow-up biopsy excise. Let's see the result. Excise once again. Yeah, okay. Wonderful. So let me show you something. In this case, don't ask me why. I don't remember. We decided at this point to not excise it, but to follow up. Of course, this was a patient that underwent mole mapping anyhow, so we had a side-by-side comparison. We did not excise it at that point. And then in the next visit, what happened is this. Yeah?
Well, still, this is not a lesion.
Less concerning.
Yeah.
Well, but still.
But growing, definitely.
Growing. So this is a melanoma.
This is a melanoma. Okay.
Yeah.
So
finally.
That's the opposite mistake than before. But let me tell you, again, in my view, we are fine, because this is what? This is a melanoma in situ.
Yeah.
So everything is fine in all these scenarios. So that's the third lesion. Fourth lesion in the same category, clinical, close-up, dermoscopy. Let's make the long story short. So would you excise this one?
Yes.
Sure.
Yes.
Sure.
Okay. Excised once again, solar lentigo. So in these 4 examples, we had practically one melanoma only. So of course, this is a kind of mistake that we do often, because some lesions do not follow the patterns that we know. But in my view, none of these 4 cases that I showed you, including the melanoma one, is a severe thing. None of them is a severe thing.
No.
Everything is fine. with all these 4 lesions.
False positives are there. There are many, and we don't care. I mean, we know we have to accept the rule.
The only thing I would change was the first case that I would do a partial biopsy before doing the entire excision, just because it was located on the face. Next one, flat again on the leg, clinical dermoscopy. What do you think? No Paul here. What do you think? Should we excise it? No Paul. Should we excise it?
Yes.
Yeah.
Of course, yes. Okay. We excised it. And the diagnosis histopathologically was a dysplastic nevus. This was an old case, so I don't remember the details of the story. I don't remember what happened and why the patient did not undergo a wide excision later on. The point is that the patient did not do it, and this is what happened 2 years later. You see that we have the recurrence of a melanoma, which is not in situ anymore. So this is another kind of mistake, which is not directly because of the clinician, but indirectly, it's also within our responsibilities to take care of this potential problem. And when the histopathologic examination is so much in contrast with the common sense and with the clinical and dermatoscopic morphology, we have to make sure that the mistake will be corrected. Something a little bit more severe now. No, already the previous one was more severe. Take a look at this lesion, very recent one. It's an ulcerated nodule. So already clinically, we know that it's very probably something malignant. It's extremely unlikely that dermoscopy will change our mind concerning this. That's the clinical, confirms that this is something malignant.
We just have to decide if it's melanoma or BCC,
or something else, The point is, so if I ask you to put your coin on one specific diagnosis, would you put it on BCC?
Yes, BCC.
Yeah,
Yes.
infiltrated.
Yes.
I would go for melanoma.
Yeah, because you could go for melanoma. Yeah. The point is that there is a large ulceration, but at the periphery, look at the lower part. I mean, this area reminds to me a lot of basal cell carcinoma. Also the upper area.
Yeah.
Here, the problem is that this was, of course, scheduled to be excised, yes, but under the diagnosis of BCC, which means with a waiting time of some weeks, maybe more than a month. And unfortunately, this was a quite thick ulcerated melanoma, which is really a surprising diagnosis to me, even now that I know when I look at this image. And this gives me the opportunity to repeat the rule that the other rule that JP recently said a couple of times, which is that when you think about the BCC but you are not sure, then treat it as if it's not a BCC. So treat it more aggressively when you are not 100% sure that this is a basal cell carcinoma. More aggressively, more quickly, not more aggressively, more quickly.
More quickly.
More quickly. Very good. One more case, maybe the last. Let's say yes. Let it be the last. So you understand which is the scenario here. You see, difficult to manage patients with this severe sun damage. A lot of actinic keratosis, but among them, possibly, also invasive squamous cell carcinomas. So, what would you do in terms of management? Quickly.
Well, quickly, I would try to be concentrated on the real problems now. So then all the rest, okay, we will treat all these actinic keratosis afterwards, but we have to check if there is a squamous cell carcinoma right now.
Oh, perfect. So to check fully all the area to see if there is a palpable part, an ulcerated part, and so on and so on. That's what we did. And we prioritized as following. This was the first one that we decided to excise. That's the clinical, and dermoscopy is not so good because the photo was not so good. But anyhow, this was the first lesion that we excised, and we did a nice graft. And this was, of course, an invasive squamous cell carcinoma. This is the second lesion that we operated in the same day. I don't know if you can see it in the photograph, but this was palpable. So ulcerated, palpable, very probably another squamous cell carcinoma, which was confirmed histopathologically. And this was the third lesion on the cheek that we decided to do a little bit later. Here, do you think that it could also be a basal cell carcinoma somehow?
Looks
If you
like a
look at
melanoma. I think
Um,
melanoma. This is a melanoma.
Yeah. So that's the point. The point is that by doing this check, for some reason, in this lesion, we thought, that this could go after. It's flat, if you can see, it's not palpable. And we thought that it could go a little bit later. But surprisingly, again, this was a melanoma with a thickness of something like 5.
Yeah.
Quite
Wow.
impressive. So, that was, of course, eventually it was excised, but again, it's a priority issue, what should have been done first. To show you the happy end of this story, this patient underwent pembrolizumab afterwards because it was a thick melanoma stage 2. So we still treat him with the last infusions of pembrolizumab. We did, in addition to this, some field treatments, photodynamic therapy, imiquimod, and so on, systemic retinoids, and you can see how he is today. Overall, if you compare the baseline and today, much better. Everything is fine, also with his melanoma. So no harm done in the end, but this is something that can happen, and it happens why? Because when you're looking in a cancerized field, you have, I suppose that the reason is that you have in your mind the idea that everything is squamous cell carcinoma since you are in such a severely sun-damaged skin. So it might be that something else you might overlook it.
But let me tell you, he looks even more, even younger than before. Look at
Yeah.
it.
I told you we did photodynamic therapy, imiquimod, and
But also fillers.
no, and systemic retinoids plus pembrolizumab. So he's extremely happy. He's one of the happiest patients that we have today. So
Pembro for rejuvenation? That's the whole
I
idea?
don't think it's pembro. Let me tell you, this is very interesting. Systemic immunotherapy, when you administer it for either, in this case, we administer it for melanoma, but in other cases that we give cemiplimab for squamous cell carcinoma, the secondary lesions, actinic keratosis and so on, do not respond.
Yeah.
They don't improve. So I think that all this I'm sure that all this improvement is because of the photodynamic therapy and imiquimod and retinoids that we did, and not because of pembrolizumab.
Do you use a lot of PDT?
A lot of PDT, yeah. A lot.
Zepi?
Wonderful. Well, not a lot, let me tell you. I prefer still topical. Well, we do some, and we do, but mainly Efudex and imiquimod, yeah.
And you, Nisa?
Yeah, we don't have photodynamic therapy, but I'm quite happy with Efodix and sometimes Aldora. Skin cancerization is very good with these topical agents as well.
I'm also pro-topical. I've used daylight PDT several times, but the result is so dramatic. Like the patient within 2 days is horrible. So we don't take it very well.
But it's good. That immune reaction is good for the patient.
Well, yeah, but
there is a question about which systemic retinoid, acitresin is the
25 milligrams per day, long periods.
Could a shave be done in the lentigo maligna? Of course, yes, of course. The only scenario that I would discourage shave is when the dermoscopy suggests that there might be an invasive component. But in the classic scenario of these purely flat lesions that with the criteria we know, then yes, of course, shave is absolutely fine. And that's it, in my view. We got
Nisa.
No, wait.
No, wait a moment, Sebi.
Skin is the new innovation and definitely a revolution in future screening of skin. We designed this product based on feedback, based on experience all of these years, and we are happy that we finally have got an ergonomic and intelligent tool for all physicians. Looking at this product, the moment you take it off the docking station, you immediately have got live image. So you can start already working and screening the patient. If you take it in your hand and look at the features that the software, the application has, you will realize it's covering all of the missing points in a manual dermoscope. You have now access to the AMI, the Photo Finder AI. All of this in one device, the skin.
Very curious to check one of these.
Wonderful, wonderful. Before Nisa starts, JP, just remind me, you are going to tell us something later, correct? You, okay, good.
And
Nisa.
before Nisa starts, just a reminder, apart from the quotes of the day, send us your cases. Sebi will send the email, because the last episode will be from cases from the audience, so that we have a lot to discuss with you.
Okay.
Let's go, Nisa.
Okay, can you see my screen?
Yes.
Yes.
Yeah. This is the patient, 80-year-old male, and he went to a general surgeon and he said that this is nothing. I'm going to make some curettage to this lesion. And the patient would like to take second opinion and admit to our department. So do you think that it's a pyogenic granuloma or something like that?
Well,
This is the
squamous cell,
dermatoscopy.
best option. Yeah.
And
Squamous
here.
melanoma.
Melanoma.
So what's your diagnosis? Sebi.
Melanoma.
Do you have a poll?
Yeah, we have a poll. Sebi.
Mm-hmm.
Pyogenic wart, melanoma, paronychia, saban apposite.
Well, wart. I would vote for wart, but in my view, then I'm a little bit too optimistic. Yeah.
You're very optimistic.
So the majority thought that this is a melanoma. Yeah, this is for sure a melanoma, because we have here polymorphic vessels, linear, serpentine, and some branched vessels. And this is a very thick melanoma. Breast of thickness is 4.1 millimeter. And number of mitoses is 30. There was no sentinel lymph node invasion. And what's interesting is the patient is still living without metastasis with this very thick melanoma. Okay, the second question. There's a subangle lesion here. This is the surface of the nail plate, and this is the subangle clinical features. And here's the dermatoscopy. What do you think it is? Sebi. The patient again came from another dermatologist. She considered that this is a wart, and she was planning to apply cryotherapy to this lesion. And this patient also would like to take second opinion. So
Wart
I think
is the winner.
wart is the winner, but diagnosis was here Bowen's. And here is the biopsy. You can see the proliferative mass under the nail plate. And I would like to show you an example of subangle wart and Bowen's disease, and you can see the difference here. We have bleedings here in subangle wart, but there's no bleeding in Bowen's disease. So always these pinpoint hemorrhages help us to differentiate subangle Bowen's or squamous cell carcinoma from warts. Always we should concentrate on these pinpoint vessels in warts. Now another patient. This is a very interesting case. 37-year-old male, and he presented with a very tender, very painful nodular mass. And the patient reported that there was a previous history of surgery, abdominal surgery here, and there was a scar tissue there. But this surgery was performed in 1987. Almost how many years? Can you? Maybe 18 years later or something like that. There was a mass there on the scar tissue. And the patient went to a dermatologist and she said that this is a keloid, and she performed 5 times intralesional corticosteroid injections here. But the mass was getting harder and harder, and the patient admitted to our department. So here is the dermatoscopy. And can we see the votes, Sebi? The first one is keloid, dermatofibrosarcoma protuberans, leiomyosarcoma, dermatofibroma, or hypertrophic scar tissue. Which one? The majority said that this is dermatofibrosarcoma. Yeah, this is very, this makes sense, but histopathology was leiomyosarcoma here. We know that leiomyosarcoma can develop on scar tissue, and when it's expanding, growing, and when there is no answer to intralesional corticosteroids, we should always take a biopsy to exclude leiomyosarcoma. And this is a very, I think, demonstrative case. So because we always face with keloid and these sort of tumors, and when it's hard and when it's expanding and when it is very painful, we should always consider leiomyosarcoma in our differential diagnosis. And this is probably I present this case in my previous episodes, but I really like this case. This is a 7-year-old boy, and the lesion is growing fast in the last 2 to 3 months. And here is a dermatoscopy. This patient also went to a dermatologist, and the dermatologist said that this is a wart and he's going to apply cryotherapy on this lesion. The mom was very obsessive, and she again would like to take a second opinion, and she admitted to our department. So what's your diagnosis, Sebi? So yeah, melanoma and echinosis head-to-head.
Totally in the middle, which is very impressive.
Yeah, that's very good. We should always excise these sort of chaotic nodular lesions to exclude melanoma, even though melanoma is extremely rare during pediatric age group. This is a case of melanoma, and unfortunately, you can see the lymphovascular invasion here in the last slide. In the lymphatic channel, you can see the invasion here. Breast of thickness was 3.2 millimeter. And there was in the sentinel lymph node biopsy, there was involvement, and involvement was extracapsular involvement. So yeah, I know during pediatric period, we should keep our biopsy threshold very low, but in cases of atypical staphyloid lesions, we should always perform biopsy before some cryotherapy or electrocauterization. Yeah, this was my last case.
Excellent.
Thank you.
Wonderful cases.
Wonderful, fantastic. A couple of questions I think we have.
I saw one very interesting regarding
Which one?
a very interesting question. So, if lentigo maligna is suspected on the face, is a 4 millimeter punch biopsy completely sufficient, or should we biopsy with at least a 5 millimeter punch?
Yeah.
I think that the answer to that is that punch sometimes for lentigo maligna is not sufficient. The best answer that you can get will be like an atypical melanocytic proliferation, which you could also get from, I don't know, an atypical gentigo lentigo. shave, I think, is preferred for lentigo maligna on the face. I don't know if you have any different, or complete excision if possible. Do you have any different opinions, Emilios, Nisa?
I agree. Since a few years that I started using shave, I also prefer it. But on the other hand, it is sufficient, I would say, because even if you get the response that you say, atypical melanocytic, then you have your answer. You know that this is a lentigo maligna and you have to treat it accordingly. So in general, since the differential diagnosis includes non-melanocytic lesions like solar lentigo or actinic keratosis, even a punch could be sufficient. The only problem, the only trap with punch biopsies, in my view, are collision tumors that on the face, it's frequent that you have a lentigo maligna and also a solar lentigo or an actinic keratosis.
In actinic keratosis, like it is really some damaged skin, we very often see like solar lentigo adjacent with actinic keratosis and a lentigo maligna overlapping it. So that selection, you're very punctual on this one. Point selection for the biopsy is very important.
Yeah, but for example, in the case that I showed you at the beginning, which eventually was a solar lentigo, but it was a lesion with a quite homogeneous pattern all over it, a punch biopsy would be fine. I mean, because it would exclude melanoma.
Can I ask you something?
Yeah.
Especially in that one. If you got back on that lesion, looking like that, from a punch biopsy, the diagnosis of solar lentigo, would you be satisfied?
Yes, and I've worked on this with our pathologist long. I don't know if this is only our pathologist because they are not very experienced with this topic, but I think that in general.
Is he Matthias Emilios?
Yes. I think that in general, solar lentigo, especially in a lesion like this, usually can be discriminated. Because there will be not at all nesting of melanocytes. Of course, also in lentigo maligna nesting is not predominant, but for sure there will be an increase of the number of melanocytes in lentigo maligna. So usually this is not the problem, receiving the diagnosis of solar lentigo and then in the end proving to be lentigo maligna. The problem is what you said. You receive diagnosis of atypical nevi, atypical melanocytic proliferations, and so on, atypical melanocytic tumors. So all these should be interpreted like lentigo maligna, practically. Yeah.
Totally agree.
If the lesion is big and it has more patterns, should be a good idea to do 2-3 punches. Yes, exactly. Of course, great idea to do 2-3 punches or shave biopsy.
Shave is better.
I agree that shave is better, but I don't insist because I know that many colleagues, especially in some countries, they are much more familiar with using the punch biopsies and not so much with shave. So
it's very interesting.
The result of punch biopsy on the face is not so good, isn't it? Maybe it's better to take an incisional wedge shape biopsy than punch biopsy on the face. Scar tissue doesn't look so nice.
Yeah, but 4 millimeter is 4 millimeter. Anyhow, it's not. It's a small.
In Greece, we don't use shave that much. We use more punch. In contrary, in the US, they use shave so much. They love shave. It's a good biopsy. Shave biopsy is a good biopsy.
Yeah. Agree. But for lesions located on the face, because in the US, I think that they overuse it also for lesions located on the trunk.
They do.
Does not make sense in my view.
They do.
Yeah. Wonderful. Do you accept junctional nevi as result of biopsy on the face? No. That's what we said.
Never.
No, we do not.
No.
It's melanoma.
Solar lentigo, we accept actinic keratosis, seborrheic keratosis, and that's it. All the rest, lentigo maligna. Speaking about flat lesions, of course.
Of course.
And I think we took all the questions. So Konstantinos, if you are ready to go.
Absolutely. So mistakes, not a happy topic for anyone. We're not.
No, I mean, mistakes is the happiest topic in my view. I enjoy when I show my mistakes pretty much.
Really?
Yes, a lot.
As long as they're not, they're not very bad. So for my first mistake, I saw this on last year's episode as well. And the reason that I'm sharing it again is to highlight, Emilios, what you said on your cases as well. So this is a 40-year-old patient presenting with this lesion on the scalp, and this is the dermoscopy. I would ask the audience to just write what do they believe this is. Write in the chat if you may.
Sebaceous. You're doing a poll?
No. I'm just asking the audience to write.
Yeah.
We have one answer.
Sebaceous carcinoma.
Sebaceous carcinoma.
We have one answer for melanoma. Yeah, but now everybody is very careful because they know that the surprise is coming. That's why they say all of them melanoma. Boroma is also an answer.
That is very true. So
I think that maybe the most reasonable answer is the one given by Roniel. Squamous cell carcinoma or sebaceous carcinoma are the most probable diagnosis based on what we see. Xanthogranuloma, adnexal.
My diagnosis is excisionoma.
Yes, excisionoma.
Yeah.
Of course.
So again, my diagnosis was also versus sebaceous carcinoma and squamous cell carcinoma, which unfortunately put this lower in the list of surgeries. So instead of having this excised within the 3-week period that we usually do lesions suspicious for melanoma, this was excised 3 months after the time that I saw it. This was a 7.2 millimeter melanoma and metastatic in the lymph nodes. So I keep this actually in my desktop to always remind me that pink and nodular, just include melanoma in the differential. It doesn't matter that the surgery will be a little bit overrun. This is a case that haunts me. Of course, the patient was scheduled for excision. He did take it out.
Yeah.
However, the delay kind of hurt me a lot. Yeah. So this is why I put this again, because this is a mistake that really hurt me. So this is a patient that
we love it. We love it.
You love it, exactly.
Yes.
So this is a patient that I saw 3 years ago, did topical treatment for, she had multiple actinic keratosis. It's a female. She had multiple actinic keratosis, did topical treatment, excised a couple of lesions suspicious for cancer, and 3 years after, she comes with this image. The thing is that I didn't see her in the first place. So a colleague that saw her first performed a wide excisional biopsy from here, believing that all of this is squamous cell carcinoma. She came to me afterwards with the biopsy result, although Emilios has said, we love this entity now that we've learned how to identify it.
Yeah. But someone wrote already, erosive pustulosis, yeah.
Exactly. So this is the patient after 3 weeks of corticosteroid treatment. However, this is the area of the surgery, and this will never heal as well as the rest. So always keep pustular erosive dermatosis of the scalp, especially in patients that have had prior treatments with imiquimod, 5-FU, etc. Another case. Pardon me?
Paget.
So yes, this was an extramammary Paget disease. However, on the beginning, so it's an elderly gentleman. Patient was seen by me, and at the beginning, to be honest, I thought of a fungal infection. So I prescribed regional treatment. And came to me after 2 months because I told him to see him back in 3 weeks. He didn't come. So actually, no, he came back after 3 months, and he had already developed this
Wow.
extra lesion.
That's unusual.
It's
Very
yeah.
unusual. Very unusual.
Yes, yes. Within 3 months, he developed this extra lesion, which dermoscopically looked like this. So I should have done the biopsy from the very beginning because I suspected possess, but I just wanted to rule out fungal infection. So I gave him the creams. I was like, okay, see you back in 3 weeks. If it hasn't subsided, we'll do a biopsy. Patient didn't come. So had I done the biopsy earlier, the patient would have moved way faster. He did the surgery. He's okay right now. The tumor was completely excised.
But what was this nodular lesion diagnosed as a what? As a
Metastasis.
Pardon me?
Metastasis of the
what
pagette.
was the histopathologic diagnosis of this nodular lesion?
Extramammary Pagette disease.
Well, but extramammary patch disease is a carcinoma in situ. Was this still in situ? The
Yeah. It was still inside. It was still inside.
Okay.
It was still inside.
The strange thing is that it's not connected with the main part of the lesion, so it was, I mean, somewhat.
Yeah.
Anyhow, strange.
I have no idea. I really have no idea. I was very surprised when I saw the patient back, to be honest, with this lesion. Nonetheless, I biopsied multiple points. So I did 5 biopsies. So mapping biopsies from here, and here, plus a couple of biopsies from here. They were all interpreted as extramammary Pagette disease. Still, my mistake, didn't do the biopsy from the very beginning and waited for it.
Well, the point here is so the let's say the teaching point here is that patient, when you delay let's say the treatment or the management decision, then the patient could not come back when
Exactly.
you say, yeah. And this is a little bit the point when we say this is a nodular lesion covered by a crust. Come back in 3 weeks after applying keratolytic stuff. You know, we should avoid to delay the diagnosis. We should, yeah. So that's the teaching point you wanted to mention, yeah.
Exactly. This was exactly the teaching point. So you can't rely on the patient to conform to your schedule.
Yeah.
You should make the schedule.
Yeah.
So, Santos, how did you treat the patient finally as a result?
Surgery. Yeah. And he's now like 6 months post-op and he's doing fine. It was resected with clear margins.
Interesting question. Was the pagette extramammary associated to another neoplasia?
No.
No. And interestingly enough, I have to say that in my experience, I checked
Never.
recently. Why
Never.
mammary pagette is always associated with
That's so interesting.
Extramammary pagette is, in my experience, almost never associated with anything else.
I also experienced very good results with Aldara, topical Aldara.
Yes.
Have you ever tried?
Yes, many times, but my experience is not so successful. Yeah.
So radiotherapy is the first line treatment.
Radiotherapy,
And
because
then
the sphincter function is affected by the surgery, especially in the perianal area, and this is so bad for the patient. So maybe radiotherapy, Aldara should be first tried, and then surgery.
So the thing is, because it progressed so rapidly within 3 months, I want to have the maximum effect. That's why I went for surgery. And also, it didn't affect the dactylios. How is it called, Emilia? The perineum, whatever.
Oh my God.
Yeah.
The muscle there, the muscle. For the muscle. Anyhow, we understand what we're speaking about.
So he didn't have any incontinence.
Sphincter, and it's a Greek word. My God.
Yes.
Sphincter. Yeah, sphincter. Okay. Do you have more, Costa? Yeah.
So I will go with two more cases very fast.
Yeah.
Patient, 32 years old, presented to me 3 years ago with this lesion on the chest. What's your diagnosis?
Looks like dermatofibroma.
Optimistically speaking, dermatofibroma.
That's what I said to the patient as well and sent her home. However, she came back 3 years after as she watched it grow, and this was a DFSP.
Dermatofibrosarcoma, yeah.
Yeah.
So, of course, what looked like dermatofibroma and feels like dermatofibroma, yes, it is a dermatofibroma, but in rare cases, it could be something else. Does that mean that we should biopsy all dermatofibromas? No, for sure. But it's not a bad thing to instruct the patient to keep in mind, like if it starts growing, if it changes in texture, like come back sooner than 3 years after.
Or
Retro, if you go back to the image, retroscopically, of course, because I also thought dermatofibroma dermatoscopically, the size is a little bit strange. It could be okay for a scar, for a hypertrophic scar, but
yeah, the size and the location. For dermatofibroma, we should not stick on the morphology when the location is strange, because this is not really a frequent location for dermatofibroma. While in young individuals, the upper trunk is a very common location for dermatofibrosarcoma. Yeah.
Yeah. So retrospectively, that's what I kept in mind as well. Excellent. However, instruct your patients, especially in the weird locations. Of course, even now, if I saw this patient again, I would still tell her that this is a dermatofibroma. You shouldn't worry about it. However, if you see it changing, a dermatofibroma shouldn't change. If you see it changing, come back.
or you might biopsy. Yeah, you might biopsy in any case. Yeah.
Maybe.
Wonderful. Okay.
And final case, what do you think this is?
Non-target maligna.
Absolutely agree. Absolutely agree.
No, I
Well,
think
I don't agree so much, but
the follicles are very visible, which is not
Mhm.
really in line with the lendigo maligna. So it could be also a
there is
sense-
regression. There is regression, of course. There is regression.
Yeah.
There's regression.
Yeah.
But there's also brown structureless background on the lateral upper side. Can
Yeah.
you see that?
Yes. So this was a lendigo maligna. My mistake here is that this was the skin of the patient, because the other lesion is very close to the eyelid and also the eye. So a severely sun-damaged person, and because I was sure that this was a lendigo maligna, I went and did comparatively wide excision straight from the beginning so that he would be done with it. And because there is so much solar elastosis, the difference, or the surgical outcome, there's a big difference between the two eyes. Back then, when I did it, I wasn't so confident in using adjuvant imicmod. So if I did that today, I would do a way smaller excision, and follow up with imicmod. Whereas now I'm not at all happy with the surgical result that he got, especially in patients with solar elastosis. When you cut off a piece of the face, it shows. The difference shows a lot.
Yeah.
Wonderful. Could you
Wonderful.
remind us, JP, because you repeated a couple of times today, which are the most frequent locations for dermatofibroma?
For dermatofibroma, well, extremities, especially lower leg. And also, I mean, the back from time to time, but the
Shoulders.
upper part of the trunk is, I mean, at least in my experience, a quite repetitive location for dermatofibrosarcoma. Yeah. Okay, guys, I have to remind you something concerning our nice Eine products, especially today I want to remind you that Eine offers a storage and management of dermoscopic digital images with assignment on body map with annotation, risk levels, diagnosis and treatment, and also the possibility to monitoring lesions over a long time. There are two possibilities. One, it's free. So it's a free app that you can download for iPhone or Android. And it's a locally based storage of images on your phone. Otherwise, you can choose the monthly fee Derma Manager, which is an app and a software, which is provided by INI, and it's based on a cloud-based storage. And you can try 1 month for free, and then if you like it, you can apply for the fee. Just a reminder, please go to www.ini.com/dermoscopy-happy-hour, because you can win a Delta 30 Pro, and we will give the winner the result on the episode number 20, and the final episode.
There is a comment that the link did not work. I'm trying to check now.
Okay, try. Okay. Yeah, try.
Yes, it works. It works. It works. It works.
Ah, okay. Yeah. Yeah, so just go there and apply for the winning. Very good. Allora, by the way, Pascal.
I thought that you were ready to say something because you said, by the way.
Wait, we are the champions. Look at my T-shirt.
Oh, really?
Brava.
Brava, brava.
Brava, brava.
Brava, Isa. Wonderful. By the way, since the episode was on mistakes, there was a comment earlier by Blooding that you learn the most from mistakes. And of course, we fully agree, and that's why we enjoy sharing our mistakes. You know that there is a very nice saying about the definition of cleverness. You are not clever when you repeat the same mistake multiple times. You are clever when you learn from your own mistakes. You are super intelligent when you learn from other people's mistakes. Yes.
Yeah. This is a very good point.
That's a very good point.
Yeah.
Okay. Penelope for tonight. 5 cases as always, 5 nice cases as always. The question is melanoma or not. We begin with the first one for Nisa, 74-year-old, taking aspirin, warning, achromic bleeding nodule located on his back of recent appearance. Come on, already the history is saying a lot. But that's dermoscopy. Bit strange.
Oh.
Yeah, there are some hairpin vessels at the periphery, but yeah, and that's the aspect overall. So is it a melanoma, yes or not? What do you think, guys?
No.
Yes. Yes.
I would
Yes,
go
no. No or
No.
yes? No.
Yes, because there's peripheral erythema around the lesion. There's an immune reaction. So for me, it's a melanoma.
Merkel.
Okay.
Merkel?
Maybe we
Let's
follow
see.
up. We follow up and we see it in 3 months. What happens?
Yes, very good idea. Very good idea.
So it was a nodular amelanotic melanoma 1.9.
The erythema is the greatest clue. Peripheral erythema.
Yeah, the peripheral erythema, you say, yeah.
Yeah.
Ulceration also, of course, looped vessels, and somehow polymorphous vessels. Then Konstantinos, 46-year-old woman, pink nodule, 2 years, recently grown, located on her wrist. That's dermoscopy.
It's clear cut. Clear cut.
Yes.
A lot of blood, a lot of sticky fibers because of the ulceration, and then a few things that we can see at the periphery. Melanoma, yes or not?
As Debbie was saying at the prior episode, look at the periphery for remaining melanosis. So this is definitely a melanoma. I would say 8 minutes. Ah!
Allergenic.
No, come on.
Which
No.
of course,
No
which of
way.
course is extremely strange, not because of the lesion itself. The lesion itself is very ulcerated, very bleeding. So,
But
okay,
look at the
but
right side.
the periphery, yeah, exactly. The periphery, it looks that there is a flat pigmented component, which makes it so strange that the pyogenic granuloma developed on what? On a nevus, on who knows?
I would go back to the pathologist many times.
Yeah, of course. Of course. Of course. Next one for JP, 47-year-old, numerous nevi, pink again, black, located on the calf. This is dermoscopy. Here, I think that we can see something, many dotted vessels.
Dotted vessels, some gray dots. So this could be also a regressive benign lesion.
Yeah,
Or not.
Something schizoid also.
Yeah, melanoma not, I would say not. I feel optimistic.
You feel optimistic. It's not your day. Melanoma on a pre-existing nevus, clues vascular pattern of diffuse dots on a pinkish background.
Yeah.
Touches of brown. Yeah. What is difficult for me to understand here is the
Nevus, yeah.
The nevus. Yeah. The nevus. Okay, and the next one for me, 48-year-old female, not history, pink nodule on the leg, located on the leg. I think that this is, of course, I know now the case, but I think that this is feasible in the sense that we have shown many cases like this. Of course, here you see the non-polarized light, but now take a look at the polarized one. I think that we show lesions like this quite often. Don't you think so, guys?
Yeah, it's a schizoid looking lesion. Yeah.
Take it out.
Yeah. Okay. It's not your day.
No,
Clear
but it could be,
celacanthoma.
clear celacanthoma. No,
Clear
dermatofibroma.
celacanthoma. It's a dermatofibroma. Well, I said it's a clear celacanthoma.
It's not my day. Yeah, but it happens.
Neither mine.
Eventually, that was a tough one. I mean, yeah.
It's very challenging.
It's the
No
best.
one can guess. Yeah.
Get rid of the shiny white lines. The vessels do not match. There's so much vasculature.
Yeah.
But I say so because we showed and we discussed about it some dermatofibromas with many shiny white lines, I mean, covering almost the entire surface of the lesion. And I think that this is not so frequent in other tumors to have this abundance of white shiny lines occupying the entire lesion. But anyhow, of course, this lesion goes to the rule that it's a nodular lesion. You cannot be
It should be excised.
therefore not.
We know what to do. We know what to do.
Exactly.
Who cares? Who cares about the preoperative diagnosis in some way? In some way.
And the last one for Sebi, 65.
Heavy, you look so bright today. He looks so bright.
Yeah, no beard, no beard. Yeah, bravo.
So there is an echymotic halo, but then what's going on in the middle of?
Wow, this is a targetoid stuff. Yeah.
Targetoid something.
Dermatofibroma.
Targetoid something. Melanoma, yes or no? Melanoma, yes or no? Melanoma, yes or no?
No. For me, no. It's not melanoma.
Maybe. Are we sure that it's not melanoma? It's not melanoma.
No, we are not sure about anything today.
Lipidized dermatofibroma.
Sorry. So it's just a pigmented purpuric thing. Maiocchi. Yeah, the annular one is Maiocchi. And we can see, of course, the echymotic halo and a little bit of purpura. Wonderful, very challenging cases today, Penelope, I have to say.
By the way, you know that Sebi was forwarding me the last paper that Penelope published on porokeratosis.
No, but that's what I'm about to say. That's what.
Sorry. Say it.
I'm about to say that there is also an additional special gift, but she said that it's for you, specifically for you.
Okay.
And that's, of course, I mean, we cannot go through the paper now, but this is, I went quickly, and I mean, it's so nice. I mean, she collected a wonderful collection of examples of porokeratosis located anywhere on the body, including the face that, last week we saw a case, and we commented that it's rare. So that's a very, very nice educative paper by Pascal that, of course, we recommend you to read. You will find really wonderful examples of porokeratosis here, and also not only the examples, but also a classification, theoretical knowledge, a classification of the various subtypes of porokeratosis. Wonderful.
Looks like an atlas.
So,
Bravo, Pascal.
Time to go.
Without Kahoot?
Time to go for Kahoot. There is another quote. If you have a lesion that you cannot prove, don't make a mistake.
I know. I saw it. I saw it.
Okay, good.
Yeah, I included it in the.
Yeah. Okay.
Okay. Accept cookies and start. Get ready to join.
Yes.
Guys, are you feeling sad that season 3 is coming to an end soon?
A little bit, yes. Yeah.
Actually, yes. And I really loved this episode. Like, this was a very educative episode.
Yeah. I told you earlier, for me, this kind of discussion about mistakes is the best, I mean, the most enjoyable.
Yeah, it's so, I learned in every episode, which is amazing, but in this episode, I've learned so much. I also saw mistakes with your cases that I have already done, so.
Should we go?
I think that in 5, 4, 3, 2, and 1, we should go.
Just one mistake. Oh, you started. Okay.
Okay.
I just want to highlight one mistake. Suspicious lesions. That has happened to me a lot. Suspicious lesions.
Wait, Konstantinos, because we started.
Sorry, you started.
So, quote, expert or beginner, whatever, obey the rules forever. Suspect the worst, expect the best. In a lesion you cannot prove, don't make a mistake, why not remove? All three are nice, in my view.
Yeah.
Tonight.
Nina, I'm so sorry, I prefer the first one.
And the winner is
Nisa.
Marginally the one suggested by Nisa. Suspect the worst, expect the best.
Wow, very nice, because this is also in some way a little bit philosophical, Very good, perfect.
Yeah. But I also like so much the first one that maybe we can put it, we can bring it back in the next episode. I mean, it's gonna fit anyhow. So suspect the worst, expect the best is also very nice, very, very nice. Wonderful. Case number 1, that's the clinical. That's dermoscopy. You see how nice I am today. It's because of the championship of last week. I feel, very generous. And let's see the options. Diagnosis. Discoid lupus, BCC, dermatitis, rosacea.
Oh, but that's very, very gentle from you, because you avoided to put in the conversation actinic keratosis.
Of course, I would never do it. Okay, woo, yes,
Wow.
yes. It's so nice that, come on, it became so easy to recognize discoid lupus with dermoscopy. Yeah? I love it. And K, MK, and LEVA are in the first three places, which brings us to case number 2, which is very cute. Look at it.
Nice.
Wow, it's a word.
That's clinical. That's dermoscopy. Don't speak, don't speak, don't speak.
Incredibile.
There was a nice paper that came out on
Don't
this.
speak.
Really? Really?
Yeah.
What's this? Lavra migrans, sarcoidosis, BCC, or Lichen-planus.
Is there a paper on
Yes,
on
yes,
that
yes, yes,
specific
yes, yes.
morphology? Yeah? Huh?
Yes. On this linear thing.
Yeah, yeah. Interesting.
But do you like the choices that I included, like Lavra migrans, which got also the majority?
Of course, Lavra migrants got many. Yeah, yeah.
To be honest, I was very sure for the diagnosis before I saw Lavra migrans. I was like, oh.
So a linear basal cell carcinoma. Wonderful. What happens here is that K is still in the first place, followed by
Gianpaolo, my Gianpaolo,
Your Gianpaolo.
my Gianpaolo.
Case number 3, on the palm. Clinical dermoscopy, unfortunately a little bit blurred, but in my view, the features are visible. Let's see the options. What is this? Is this a wart? It's a poroma, pyogenic granuloma, or melanoma?
This is.
Okay, you're in a very good mood, Emilio, today.
Am I?
But since this is not my day, I will avoid to say my opinion.
The obvious.
Poroma, che bello, che bello.
Poroma, poroma, poroma. By the way, for poroma, we are the most famous vascular structures are these cauliflower-like, but the most frequent vascular structures are these. They had been described in one paper. These very large red globules. So they are too large dotted vessels. Like
yeah.
These are the most frequent ones. And what happens here? Still, nothing changed.
Nothing changed. Yeah. Wow.
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 Impressive.
Is
number
K
4. Huh?
is K the K that we suspect? Casia?
The K that we suspect. Who knows? Who knows?
Probably she is Casia.
That's the clinical. This is dermoscopy.
Mm-hmm.
I think that there is something interesting in this lesion. I guess you agree. And of course, predicting the breast lobe thickness is the question. Tell me your opinions.
0.9.
2.
1.4.
My God, Jeppy, today was not your day, but in the end, you changed everything. You found the precise thickness, not.
Really?
Oh my God. I mean, not close, the precise thickness.
I'm an histologist. I am a pathologist.
That bluish area.
I expected it to be way deeper.
I thought that it was thicker because of that bluish invasive area.
By the way, lentiginous melanoma, lentiginous melanoma, lentigo-malignant type melanoma, mainly with this focal invasion. Let's see what happened. Gianpaolo is the first.
Vai, Gianpaolo, vai. He's struggling since many episodes.
Last case. What?
No, I like it. I don't know what it is, but I like it. Yeah.
It's a pink nodule. It's a pink nodule. We don't like pink nodules.
But with clinical, what would you vote as a more preferred answer?
Melanoma? Pyogenic granuloma?
It's on the back.
Or it's here? Spitz? Yeah, Spitz.
Hmm. Of course, we are not anymore used to make diagnosis with the clinical only.
Yes.
Okay, so now don't speak because we have to vote. Diagnosis. Do you think that this is an angioma, melanoma, squamous, or basal? Okay, obviously easy for our attendees, for our audience. But look, this amelanotic melanoma, how it retains the symmetry. I mean, especially from a clinical point of view.
Yeah.
But I think that with dermoscopy, we can do it, as the majority of you did. And now let's see the podium. Third place goes to Lovr.
Lovra is an
name.
old friend of us.
And yes,
Gianpaolo, finally. Yes, probably the fact that he moved to Lyon was making him lucky enough, you know. Yeah.
Guys, the first place is Teona. Teona is me.
Yeah.
And because today is Teona's birthday, you all know Teona very well, and
yes,
lost her 3 years ago, and
Bravo,
today is her birthday. And happy birthday, Teona!
Happy birthday!
Happy birthday,
Gianpaolo!
Ciao, ma mi vedete?
Sì.
Hello. Hello, everyone.
So Gianpaolo, it means that you have to stay in Lyon a long time because this is making you lucky.
Okay. I'm staying here for another year.
Gianpaolo.
No.
Gianpaolo.
Come back.
No. Let me tell you. You know that you are in a place which is a paradise for wines. Do you know this?
Yes, I'm drinking a lot of wines.
Yes. You have. Oh, show me what's that?
It's Bordeaux. It's both.
You are in Lyon and you are drinking Bordeaux. No.
Oh yes, no, but it's one is Bordeaux and one is from here. I'm democratic. All the wine from French.
Enjoy.
Very good.
Gianpaolo, you beat me. Congratulations. I was in the fourth place.
Forza Galatasaray.
Thank you.
Grande.
Wonderful.
Va bene, ragazzi, see you next Monday with the last episode.
No.
Last episode question mark about the topic, but we know already the topic of the last one. So your cases. So send us your cases for the last episode.
And actually, along with your cases, if you want, send us your questions. So what was your differential? To see what the audience votes.
Yeah. Good.
Wonderful.
Bene.
Thank you all so much.
Baci.
Thank you.
Enjoy.
Ciao.
Ciao, Giappam.
Ciao.
Ciao.